Hi, everybody. We'll get started. My name is Alison Barkoff. I am the Hirsch Health Law and Policy Professor at George Washington University, and I'm also really privileged to be a senior fellow at the National Academy of Social Insurance. I'm a longtime disability and aging advocate, and am really thrilled to have everyone here today for this LTSS webinar. I am joined today by two colleagues and people who have been working on this issue for decades. The first is Marc Cohen from UMass Boston, who is the co-director of the LeadingAge Long-Term Services and Supports Center, as well as a professor in the gerontology department. And the second is my colleague, Howard Gleckman, who is a non-residential fellow at the Urban Institute, prolific writer in Forbes, and wrote the book Caring for Our Parents. Just to give a little welcome on behalf of NACI, we decided to hold this webinar today on long-term services and supports because this is such a priority, both for NACI in terms of seeing this as a critical social insurance issue, but because this has become such a visible issue. And as you'll hear about today, both on policies that are really restricting access to long-term services and supports, as well as momentum to really build a robust long-term services and supports system. So both on defense and looking forward. As you'll hear from us today, hopefully this is an issue that everyone sees themselves in. This is an issue that crosses aging and disability. It relates to family caregiving. It relates to the direct care workforce. And so hopefully many of you will really see something that you can engage in here. So with that, I will mention we have CART on here. Hopefully people can access that. And Kenya, if we want to put up the slides and get started. Okay. So I'm going to start off by talking about just some basics about what we even mean by long-term services and supports. You'll then hear from my colleagues about some different barriers and issues, and then how policy has really been developed over time. So what do we even mean by the term long-term services and supports? What we mean are things that help people who need assistance with daily activities, things like getting dressed, bathing, managing their finances, going out into the community. And you'll sometimes hear these two different words. One, activities of daily living, which are really about kind of personal care, and then the instrumental activities of daily living, which are about going out into the community and things that help you. Next slide. When we use the word LTSS, there's actually two different types of long-term services and supports. Long-term services and supports can be provided in institutions like nursing homes. They also can be provided in one's own home or in another type of community setting. And we'll talk about the two differences there. Next slide. As we think about long-term services and supports as a policy issue, this has been something that has certainly been a priority for the aging and disability communities for a long time, but we have a huge growing need. We have a huge number of people, 1 in 5 Americans who will be over 65, and the older population of people 80 plus will more than double by 2045. More than 70% of people who are older will need long-term services and supports in their lifetime. And the older you are, the more significant your long-term services and support needs will be. In addition to a growing aging population, people with disabilities are living longer. For example, people with intellectual disabilities, their lifespan has increased over the last generation from people living in their 20s to nearly their 70s, and many of them are with aging parents. So again, huge growing demand across aging and disability for long-term services and supports. Next slide. I think this visual just really highlights the huge growing aging population that really is driving the need for solutions in long-term services and supports. Next slide. So as I mentioned, there are two different types of long-term services and supports, institutional or community-based. And what we call the services in people's own homes are called home and community-based services. We know that the vast majority of older adults and people with disabilities are living in their own homes and communities. I think most people mistakenly think older adult and think nursing home, but that actually is not true. And when we look at what are the preferences, the vast majority, over 90% of people prefer community-based to institutional care. It's not just preferences, but home and community-based services are cost-effective, about a third the cost of nursing home care, and lead to very positive results in terms of quality of life, unmet needs, as well as decreasing hospitalizations. I will also mention, and I think it's really important in this moment in time, with many things happening, with potential rollbacks of civil rights, but people do have a right to receive services in their own homes and communities instead of institutions under disability rights laws, like the Americans with Disabilities Act and Section 504 of the Rehabilitation Act, which covers people with disabilities of all ages, including older adults who have long-term care needs. Next slide. Okay, so I'm going to talk now about what our current LTSS system is. And I put the word system in quotes because, as you will hear across all of today's speakers, we do not have an actual system in this country. Next slide. So when we think about what funds long-term services and supports, it is not generally Medicare, although as I'll talk about, people mistakenly believe that. Most people cannot privately pay for long-term services and supports, and there is quite a small market for long-term care insurance. So our major funder for long-term care in this country is the Medicaid program. Next slide. I'll just briefly mention, most people believe that Medicare covers long-term care, but it doesn't. It covers very short-term stays in post-acute nursing home, and there is an in-home benefit, but it is much more narrow, and it is much more medical. So as we hear later about big ideas to reform Medicare to create some type of in-home benefit, know that that is a new thing, not what exists right now. Next slide. When we also look at private pay for long-term supports and services, if you look at the dotted line on the right, you can see this is the median household income for older adults, about $60,000. When you look at the actual cost of in-home support, nursing home services, even just day services, it is completely inaccessible to most people to be able to pay. And there's just such a group of people that's often called the forgotten middle that have too many resources to spend down onto Medicaid, at least immediately, but don't have the resources to pay out of pocket. Next slide. In terms of Medicaid, which again, this is really the foundation of the long-term care system currently. As I mentioned, there are two types. There's institutional long-term services and supports. And that is a mandatory service, meaning if someone is on Medicaid, they meet an institutional level of care, a state must provide that type of care. We talked about home and community-based services. That's an umbrella term for a wide array of supports and services. It can cover things like personal care, in-home nursing, day programs, home modifications, durable medical equipment, transportation, supports for family caregivers, home-delivered meals, and more. It is an optional service under Medicaid. And I'm going to talk about why that makes a difference. But if you look at the far right-hand graph, you can see about 70% of home and community-based services are funded by Medicaid in this country. Next slide. Over time, when Medicaid was initially passed, there only was institutional care. And because of advocacy, because of changing preferences, since the late 1980s, there has been an option in Medicaid to provide home and community-based services. It started through something called 1915C waivers, where someone has to show they meet an institutional level of care and that it costs the same or less in the community than in an institution. And while it is optional, every single state offers waivers. As I mentioned, there is, under disability rights laws and a watershed Supreme Court decision, a right to receive services in the most integrated setting. I will mention a lot is happening around that right now, including a new interpretation from the U.S. Department of Justice, taking a completely different position than it has taken for the last 50 years in what disability rights laws mean and what the Supreme Court's Olmstead decision means. But the law is the law for now. And Olmstead has really led to states rebalancing and moving away from institutional care, and Congress passing more and more authorities, all of which are optional. But as you can see over time, from the 1990s to now, there's been a huge shift in funding, with the majority, 64%, of spending going towards community services versus institutional care, and about 80% of long-term care recipients through Medicaid receiving services in the community. Next slide. And you can look, it varies. Medicaid is a state federal program. What the program looks like in Georgia and its priorities around optional home and community-based services might look quite different than the priorities in California. So you can see, while almost all states spend more than half, some spend even more. Next slide. I'll just also mention, while we are mostly talking about Medicaid as the foundation, there is a program called the Older Americans Act, and it is really a forgotten and underappreciated part of the long-term services and support system. I think of it as wrapping around. It provides supports to 1 in 6 older adults and helps them remain in their own homes. It often reaches people who are near Medicaid eligible and may help prevent them from having to spend down onto Medicaid. It provides many services that are similar to the kinds of things that I was talking about under Medicaid, things like in-home supports and transportation, day programs, respite, and family caregiver programs, and it has a very incredible return on investment. But unlike Medicare and Medicaid, which are mandatory entitlement programs, meaning if someone is eligible, it must be funded by the federal government, the Older Americans Act is a discretionary program. And if you look, it is about 75 times smaller than the Medicaid HCBS program, but small but mighty. Next slide. So let me just talk a little bit about the barriers and risks that we are facing to home and community-based services before I pass it off to my colleagues to share more. So next slide. So within Medicaid itself, there is structural barriers. Medicaid is a poverty program. It has very strict income and asset limits, and people have to spend down to become eligible. That creates so many disincentives and barriers to working and to saving, and that's incredibly problematic. Second, as I mentioned, Medicaid has an institutional bias. While people have an entitlement to care in an institution like a nursing home, home and community-based services are optional, which is why we have more than 600,000 people sitting on waiting lists across this country. In addition, Medicaid pays for room and board in an institution, but cannot pay for housing in the community. Finally, I don't have to tell people here that Medicaid has become incredibly political. We're facing nearly $1 trillion in cuts, waste, fraud, and abuse allegations. That is a challenge. Next slide. I'll briefly mention that HR 1 or One Big Beautiful Bill Act has really increased the pressure on states' Medicaid budgets. And while the bill does not itself reduce funding for long-term services and support specifically, it reduces significantly federal funding to states for their Medicaid programs, putting pressure on them to reduce funding. And of course, the first thing to go, unfortunately, are optional services like home and community-based services. Next slide. I am working with others, including Marc, on trying to track what is happening in states. There are many ways that programs can be cut, whether eliminating programs or new caps, cutting provider rates, having higher eligibility, lots of different ways this can happen through legislation or budget proposals. And we know that they can have very significant impacts like longer waiting lists, more people in nursing homes, and more people having to step out of the workplace to provide care. Next slide. I just put a link here to a project that Marc and I are doing along with others, tracking in real time what is happening. I encourage people to go there. If something is missing, please let us know. We think it's incredibly important in service of advocacy to document and to also be thinking about strategies when we may be in a different political climate. Next slide. I'll just mention and end with some early trends. We are seeing that a lot of states are taking action now. You can see mostly they are cuts, and we expected not much would happen until 2027. The message is it's happening now, and it is probably the tip of the iceberg. Next slide. I'll just briefly mention that as part of this administration's efforts around quote unquote fraud, waste, and abuse, there is this narrative that Medicaid is rife with fraud, particularly home and community-based services. There is now kind of a narrative that home and community-based services are paying for things that families should be doing. And there has been major enforcement efforts in several states focused on the fact that programs have grown. And we know from my earlier slide, they have grown because that is what people want. That is because of demographics. And this is pretty existential. Next slide. So I will just end by saying, hopefully this whet your appetite. We will be sharing all these slides, and I will kick it now to my colleague Howard to share some more context.
Well, thanks very much, Alison. My job here is to talk about the gaps in LTSS. And as Alison said, we resist calling it a system because it isn't really a system at all. But there are a great many holes in whatever it is you want to call it. Next slide, please. So here are just a few. These to kind of get you a framework for what I'm going to be talking about. So the first one is care for people who require LTSS is deeply fragmented, and it's often insufficient. There's a tremendous shortage of caregivers, both family caregivers and paid aides. There's a lack of support for family caregivers. Family caregivers are the bedrock of our care system, and they do it with little training and little assistance. There's no place to live. Alison mentioned people want to stay home, but if you're going to stay home when you require care, you need someplace that's affordable and someplace that's safe. And for many people, that just does not exist. Alison also mentioned briefly the question of middle-income households. We often think, when we talk about long-term care, we think about low-income people and Medicaid, but the reality is there are tens of millions of middle-income people who will never be poor enough to go on to Medicaid. On the other hand, they don't have the resources to pay for LTSS on their own. And finally, there just is not enough money in the system. So let me go through some of these in a little more detail. Next slide, please. Let's talk about the fragmented care. And it starts with this gap between medical treatment and LTSS. Many people refer to this as the original sin of Medicare and Medicaid. back in 1965, Congress intentionally, explicitly made a decision that Medicare would pay for health care and Medicaid would pay for what was then nursing home care. And when they created that division, they created an environment where the cultures are different, the language is different, the goals are different, and most importantly, the payment system is different. Uh, when I talk to physicians, they're often quite candid about uh, why they don't help their patients, help direct them to supportive services. And essentially, they say, nobody pays me. I don't get paid for doing it. I've got too much to do already, so I'm not going to do it. And that's the system that we've created. So when I talk about fragmented care, keep in mind, keep in the back of your head, an 85-year-old widow who's living alone. She's got early stage dementia. She's got congestive heart failure. She's maybe got arthritis. She's seeing a primary care doctor. She's seeing a cardiologist. She's seeing a neurologist, and she's seeing a rheumatologist. And she needs rides to the doctor. She needs help with her nutrition. She needs physical therapy, and she needs help managing her medications. Some of that is explicitly health care, and Medicare will pay for it. Some of it is kind of this hybrid. It's not quite health care, and it's not quite supportive services. And some of it, like rides to the doc, that's explicitly not health care. And she is basically on her own. Um, There are, however, a few integrated care models that work. And so that my presentation isn't completely downbeat, I want to just briefly mention those. Next slide, please. So in original Medicare, there are a couple of initiatives. These are mostly demonstration programs, so we don't know how they're going to work yet. First one is called GUIDE. It was created by the Biden administration and continued by the Trump administration. And GUIDE is a program that pays physicians and other Medicare providers a capitated monthly fee of $200 or $300 a month to provide a range of what used to be considered non-medical services to families or people living with dementia and their families. For example, helping them with care navigation. Now, this is extremely important because it's really the first time that Medicare acknowledged that supporting family caregivers is part of its remit. It used to take the position that we don't do that, we don't pay for that. But now in this demonstration program, it is. There are about 700 providers who are participating in this. It began just about a year ago. We don't yet have any data. Anecdotally, when I talk to physicians, they're not really quite sure about how this is going to work, but I will tell you the patients and their families love it. Another program is called LEAD. This is another demonstration program. This is the latest version of accountable care organizations. For those of you who may be following Medicare over time, they've been trying for decades to create these accountable care organizations. Essentially, the way they work is rather than paying, say, a physician for each procedure that he does, so for each x-ray and each office visit and that sort of thing, it pays a bundled payment, a fixed payment for an episode of care. Um, the, the program ACOs have really not worked particularly well. Doctors think they're too much paperwork, there's too much trouble. So every few years, Centers for Medicare and Medicaid Services reforms the program. And the most recent reform they call LEAD. And the interesting thing about LEAD for the purposes of this conversation is that among the episodes of care that it will pay for, that explicitly discusses in the proposal, is the idea of paying for preventing falls. This again is a tremendous change in the way Medicare treats patients. Until now, it would pay whatever it took to fix the broken hip and pay for the rehab for somebody who fell and injured themselves. Now, what it's saying to doctors is, we will pay you if you help your patient avoid a fall. Again, it's a sea change, and it's a way to encourage physicians to reach out to maybe some of those non-medical services out there, community-based organizations and other people who actually know how to help people prevent falls. One very simple example of this is we know that malnutrition is a major cause of falls in older adults. Well, maybe a physician could help guide people to the local Meals on Wheels program. and prevent that kind of malnutrition. There's also some interesting changes happening in managed care. Now we all know about Medicare Advantage, but within managed care plans in Medicare, there are also some smaller programs that are doing some very interesting things. There are special needs plans, a number of different versions of special needs plans that are out there. Some of them work quite well, some of them work very poorly. Honestly, we need to do more research to understand why the good ones are good and why the bad ones are bad. But it is a model that provides much more intensive integrated care than a traditional managed care plan. And then the other program is called PACE. And PACE, which is a program for the all-inclusive care for the elderly, has been around for decades. And it provides a completely fully integrated care model, generally built around the idea of an adult day program with a medical clinic attached. It will pay for all of the medical care, much of the home-based services, whole physical therapy, medicines, a whole range of just basically everything that anybody would need. This is for a population they call it dual eligible. These are people who are eligible both for Medicaid and for Medicare. They are for people who otherwise would have to receive institutional care, but it's a way for them to stay at home. There's a new research paper that just came out just a couple of months ago that says that relative to Medicare Advantage, these PACE programs result in fewer hospitalizations, fewer ED visits, and during the 1 year study period, actually fewer deaths than Medicare Advantage plans. So there are some models out there that have some potential, but the problem is these are very small. PACE, there are fewer than 100,000 people in the entire country who are receiving care under PACE programs. So these are interesting ideas. They're interesting models. We have not yet replicated them nearly the way they should. Next slide, please. So let's talk about the paid care workers. There is probably 150,000 positions that are going unfilled because we have this terrible shortage of aides. Many reasons why. One of them is typical aides are women in their 50s. They're aging out. This is also a job which has a very high injury rate. It's actually more dangerous to be a home health aide than it is to be a coal miner in the United States. COVID drove people out of the business. The pay is very low. I'll talk about that in a little more detail in a minute. There's a tremendous lack of respect from employers, and those employers include not only the corporate employers, but also the families who employ these folks. Um, there are few opportunities for advancement. And then, of course, most recently, there's the crackdown on immigration, which has created taken what was already a terrible shortage and made it much worse. Before 2025, there were probably a third of care workers were immigrants. We don't really have data. We don't know how many have left their jobs or left the country, but we do know anecdotally that many home care agencies, nursing homes, assisted living facilities are losing staff, significant numbers of staff, and that's creating a real problem. And now what we have here is basically economics 101. When you have huge demand for something and limited supply, what happens? The price goes up. And that creates what's a real paradox in this world. So the average cost for a home health aide, just to take that as an example, is about $35 an hour if you hire through an agency. That aide gets about half of that, about $17 or $18. The rest of it goes for taxes and administrative costs and profits. Uh, so you have a situation where at $17 an hour, the aides are not receiving nearly a living wage. But on the other hand, at $35 an hour, the families can't afford to pay for the care. So it's easy to say we need to pay the aides more, but if we do, we're going to have to figure out some place for the money to come from for families to pay for this, and they will pay directly or indirectly one way or another. Next slide, please. Family caregivers, as I said, are the bedrock of the system, but they often make do with great love and little skill. There are very few opportunities for hands-on training. This is particularly a problem now because we're requiring more and more essentially registered nurse work from family caregivers. They're being required to manage complicated medical equipment. They're being required to do wound care. These are things that they're completely not trained to do. And hospital discharge planners don't do it. There's almost no place where this sort of automatically happens. You can find it, but it's not easy. They need emotional support. When you're a family caregiver, I was one myself, you think you're the only person in the world who's doing this. There are lots of people that'll actually help one another, but you've got to find them. And the current system has really no way to do it. And finally, you need financial assistance. Mark actually did a survey a couple of years ago asking family caregivers, what do you want? And the answer was cash. They need the money to be able to get the services that they need, whether it's getting a grab bar in the bathroom, whether it's hiring an aide, whether it's taking time to learn themselves. And all of that is missing. Next slide, please. So Alison talked about the fact that many people, the vast majority of people want to stay home. The problem is that staying home is not possible for many people. Again, think about that hypothetical woman I talked about, 85-year-old, multiple conditions, including some dementia, nobody living with her. Very hard for her to stay at home. So where's she going to live? Again, it's a huge gap in the system. There's huge shortage of affordable housing. There's an even bigger shortage of affordable housing that provides services such as social services, social supports, maybe a nurse, that sort of thing, doesn't exist. Congregate care, there are many options if you're rich. There are continuing care retirement communities, there are life plan communities, there are memory care. All of these things are out there. They can be terrific, but they're very expensive. Nobody wants to live in a nursing home. I get that, but what's the alternative going to be? And we really haven't thought much about designing alternatives to traditional nursing homes. Um, it's a funny business. It's a product that people sell that nobody really wants to buy. The reality is that you cannot make very much money, if any money at all, running a good nursing home. You can make a lot of money running a bad one, but right now it's very difficult to make any money running a good one. So that creates a real challenge. Next slide, please. So what do they need? They need income in old age, and that means we have to fix the way we save for retirement. Alison mentioned the Older Americans Act. Many of those services are critical to supporting people who are living at home. Meals on Wheels, a classic example, many others. The problem is funding for the Older Americans Act has been frozen for years. When you think about it, Meals on Wheels is an example. What do? They deliver food, buy cars. What's that mean? Food costs go up, gasoline prices go up. They don't have the resources to provide the care. The waiting lists get longer. Housing options, we've talked about. Next slide, please. So basically what we have here, huge lack of resources, not enough money in the system, limited public programs, and insufficient private savings. Last slide, please. So before I turn it over to Mark, I just want to leave you with the idea of we need to integrate finance and delivery reform. We can't do these things one at a time. It doesn't make much sense to fix delivery if there's not sufficient resources to pay for that reform delivery. And it actually doesn't help very much if you allocate more money to a broken delivery system. So as we think about reform, and I'll turn it over to Mark now, think about these two things together and not separately. Thanks very much. And Mark, you're up.
Thanks so much. Thanks so much, Howard and Alison, for doing such a great job setting the table. I actually get to talk about, I think, some positive opportunities that face us. Could I have the next slide? So I think I'm hopeful that by now, given the great presentations that Howard and Alison did, you see that basically the LTSS system, it can be viewed as a three-legged stool. There's the financing piece, family caregiving, and the direct care LTSS workforce. I'm going to talk about some of the proposals that have been put forward to reform or strengthen these various legs of the stool. Next slide. I want to mention that there's going to be a lot of content on these slides. I'm not going to cover all of it, but everyone will have access to the slides after the presentation. So what are the core problems driving financing reform? We'll start with that leg. First of all, as was mentioned, these costs can be catastrophic for families. Medicare certainly doesn't provide coverage. Medicaid, the social safety net, requires near poverty eligibility. And the private insurance market has not yet been able to deliver to the broad middle class. So what we have is really this fragmented system relying on out-of-pocket spending, Medicaid spend down, unpaid caregiving, and underfunded direct care workforce. Next slide. So there are really three major financing reform domains. There's public insurance approaches, either new insurance or expanding existing. There's strengthening the private insurance market. And there's Medicaid reform itself, which is our dominant payer. And these efforts are occurring both at the federal and the state level. And one of the major initiatives, which I'll mention a few times and is moving along most quickly, is occurring in Washington state. Next slide. So let's deal with the core reform ideas for public insurance approaches. Here I'm going to focus just briefly on the major structures. There have been discussions of just having a universal or near universal public insurance that covers, costs from day one for as long as you need them. There's another proposal out there talking about catastrophic public coverage. Here, the idea is that families, through a combination of savings, family support, potentially insurance, pay for maybe the first 1 or 2 years of care, and then the government steps in and through an insurance program and pays the catastrophic expenses. And then there's front-end models where the public insurance would pay the first dollars of expenditures, and after a certain amount, families would be responsible for paying the rest. And there are some Medicare expansion models, which I'll discuss in a minute. Now, these approaches have been out there and proposed repeatedly for decades at the federal level, but right now, only Washington state has implemented a front-end public insurance program. Next slide. What about reforming or strengthening the private long-term care insurance market? Here, there are four basic approaches. There are tax incentives that are designed to make the insurance cheaper so that the demand increases. There are public-private partnership approaches whereby if an individual purchases a particular policy form and those benefits run out, they can access the Medicaid, the social safety net program, and protect greater amounts of their assets. The third approach is a product redesign, and this has actually been happening in the private market, where more products now are based on combinations of life insurance and long-term care insurance, or annuities and long-term care insurance. And then in the employer market, which has in the past been a target for getting people to purchase long-term care insurance, there's changing the choice architecture, which means having people automatically enrolled and then have to opt out. I want to say that at least up until this point, these approaches have been put forward both at the federal level and state level, and so far they've had a relatively limited effect. Next slide. What are some of the core ideas for Medicaid reform? Remember, this is our dominant current payer. And as I'm going through these, keep in mind that a number of these approaches were actually put into effect during the pandemic. Although, as Alison and Howard have rightly pointed out, the current focus is on reducing expenditures on the Medicaid program. So first, there was expansions in home and community-based services. There have been ideas putting forward to make it a mandatory service, not an optional one. Raising the eligibility thresholds. In other words, having the reach of Medicaid potentially increase for those people who may be in the lower middle class but don't qualify for the program. Modifying financial structures, for example, having the federal government potentially pay more into the program. Howard mentioned this, integrating care financing, Medicaid and Medicare models so that integrated financing can lead to potentially better service delivery. And I mentioned in the last slide, these partnership programs where changing eligibility criteria for people who have made the decision to purchase private long-term care insurance. When those benefits run out, they can then access the program and protect greater assets. Next slide. So here are just very quickly some recent examples of federal financing reforms. The Class Act was a voluntary public insurance program which was repealed. The WISH Act by Congressman Swazi and Molinaro is a catastrophic protection program that is being discussed right now. There have been some proposals put forward on expanding Medicare. There's a Brookings proposal. Senator Wyden and co-sponsors talked about adding home care to the Medicare chassis. And I'm going to put a little plug in here at the bottom. There is a compendium that actually summarizes all of the proposals that have put forward in the last 30 years. It's just exploreltssinitiatives.org, and you can at your leisure go through all the different ideas that have been put out there. Next slide. Some recent examples of state financing reform efforts. There's Washington State, I mentioned. They're the first public insurance program, by the way. July 1st, they'll begin to pay benefits to people who qualify. Hawaii has put forward proposals on caregiving supports and now are exploring models similar to Washington, California, Massachusetts, and others. The basic idea is that there is experimentation and study going on, and in part it's to have proof of concept, and also because there's a concern that federal action is not forthcoming. Next slide. Howard mentioned some of the challenges related to family caregiving support. The next two slides just summarize from AARP and NAC some of the big problems, families have coordinating care. Next slide. Many people report their own health is fair to poor and declines. Many people have had to make direct financial payments, make workforce accommodations, and so on. So all of these challenges are basically putting the resiliency of the family support system, that second leg in the stool there, in jeopardy. Next slide. So what are some of the reform domains that are out there? So there are about 6 different buckets of reform. First, there's financial support and compensation. Here we're talking about direct payment to family caregivers, either by allowing program benefits to be paid directly to them. There are tax credits or stipends for people who expend money providing care to disabled individuals and family members. There are cash and counseling programs. Again, it allows the recipient to pay the family directly. A second domain of reforms is workplace protections and economic security. Here, I'm talking about like paid family and medical leave, job protection policies, flexible work arrangements by employers to take into account the challenges of caregiving. Howard mentioned, and there's a lot of data about the difficulty of providing family supports. And so respite care is a very important service for family caregivers, gives people an opportunity to take some time off. And so this is a third reform area where services are being provided directly to enable caregivers to be able to take a break. Next slide. Training and education and enhancing caregiver capability. There are programs to do that. Integration into healthcare systems. This is treating caregivers as part of the care team so that you can get a more comprehensive delivery of care and better integration with the family system and the direct care workforce. And then information, navigation, and care coordination. Next slide. This is just a listing of some of the federal policy efforts to support family caregiving, and you can see there are quite a few. Tax proposals, paid leave, changes to Medicaid, and so on. Next slide. And there are also state approaches, tax incentives, paid leave expansions, respite expansions, and so on. Next slide. Howard mentioned well the core problems that are driving the LTSS workforce reform efforts. Here's a nice listing of them. There probably could be many more bubbles, frankly. Next slide. I just want to quickly go through the core LTSS workforce reform domains. First, there's compensation and financing reforms. The core policy priority is making sure that more of the money gets into the hands of the people providing the direct care. And this means raising Medicaid reimbursement rates and tying them explicitly to worker wages. There have been a number of federal investment proposals, particularly during the pandemic, increasing the federal match of Medicaid, but requiring those additional funds to go directly into wages. And there are efforts to look at value-based payment reforms for workforce retention and to incentivize providers to invest in staffing stability and training. Next slide. Workforce supply expansion, immigration reform, in light of what's been happening in terms of reducing supply, recruitment initiatives, targeted pipelines, a whole host of strategies to try and increase supply. And part of that goes to training, credentialing, and career ladders, helping to make the direct care workforce more attractive. And this comes through, training for national competency so workers can cross nursing home settings, home care settings, and so on. Expanded training for specialty care like dementia care, behavioral health, and so on. Next slide. Career ladder frameworks, giving people a sense that they have a place to advance and helping to professionalize the entire direct care workforce with certification systems and registries. The next is workforce support and job quality, improving working conditions, supporting supervision models, technology supports, and so on. Next slide. To close, the most effective approaches for supporting the LTSS workforce are, number one, having a dedicated workforce infrastructure, registries, public authorities, benefits trusts, explicitly linking funding and wages, not just higher rates, but mandated pass-throughs or wage floors, career mobility, making it more attractive, advanced aid roles or training ladders, and finally, integration into system design. Workers being treated as part of the care team and not just interchangeable labor. That, I believe, yes. Thank you very much. And I think we have some time for questions now.
Great.
Great. Thank you all so much for that wonderful presentation. I think I speak for everyone in the participants who are saying in the chat that this has been very helpful. We do have a number of questions in the chat that we'd like to give some time for. Feel free to drop further questions in the chat. But I guess, Marc, you just laid out a lot of great reform options. I think one question that comes up is do you have a preference for one of those? Do you have a sense of what can be tackled first?
My own belief is I'm a person of let many flowers bloom, and that there is no single answer that is going to address all these problems. I worry a lot about the fact that the entire system is underfunded and we're relying on, underpaid workers and family caregivers who are providing in-kind benefits. So I think Howard said this really well, which is that without additional funding sources, it's sort of like moving the deck chairs around on a sinking ship. I mean, you can't do as much with financing reform, but there are many things that you can do, and states are doing them. And I would encourage states should not be discouraged. If you can't do everything, it doesn't mean you can't do something.
And Kenya, if I could just add, because I am so happy to see people on this webinar across aging and disability. I think one thing that feels really different in this moment, especially the tables where people are looking at long-term services and support reform, is historically there had kind of been people thinking about, let's think about older adults, let's think about younger people with disabilities. People are really coming together to actually think about who are the entirety of people that need long-term services and supports. How do we make sure, and I'm in, like Mark, maybe I wouldn't call it every flower bloom, but I'm not sure any one program can meet across all of the lifespan, all types of disabilities, and all level of support needs. But I think we need to be really intentional, and I'm very proud that the tables that are thinking on the other side are really trying to make sure we don't leave anyone behind. We aren't making assumptions that it is, someone who is aging, who's just going to need a little bit of long-term services, home and community-based services, and then we'll go into an institution. That's not what we need to do. And so I think that's a really important principle that now exists at many of the tables.
Great.
I do think that at some point, policymakers are going to have to make a decision about what the fundamental chassis is, what the basic chassis is going to be for this system. Is it going to continue to be Medicaid? Is it going to be Medicare? Is it going to be private insurance? One of those is going to have to be the chassis, and then you can bolt on what else you need to fill in the gaps. But we have to make that decision at some point. And what I worry about more than anything else is at the moment, nobody wants to confront that really big question. No policymakers, a lot of people like Alison and Marc do, but no policymakers really want to confront that question, or very few do. And at some point, they're going to have to, because going back to what Alison said at the beginning, this mess that we have to call a system because we don't have a better word is just not sustainable.
Right. Right. Thank you all for that. We have a number of questions in the chat about the point about fraud that you brought up, and how there's this growing concern around fraud, especially with HCBS programs. How can advocates, deal with that question of fraud? How can they continue to advocate for the program in the midst of those concerns? And what should we be doing about fraud in these programs?
So,
are you going to jump, Mark?
Yes, really quickly. So, first of all, I think it's important I think facts still matter. It's important to get the evidence out there. And so Alison and I have been doing a number of pieces on this and trying to bring data and empirical analysis and get that into the hands of advocates. And there's always a kernel of truth in almost all of these charges, that there is some. The question is the magnitude. And so, number one, we need to call out when there are dishonesty and mistruths and mischaracterizations. We need to call that out. We need to bring facts to the table, and we need to make sure that these programs are being sufficiently policed and that fraud is dealt with. Right now, all the evidence suggests it is a small issue. Alison, you want to add?
Yeah, and Zane just put in the link one of the articles that Mark and I wrote. I think just a few things to say. Increase in HCBS does not equal fraud, and that has been the basis if you look at some of the letters. We have to push back on that idea. It has been a bipartisan, multi-decade effort to increase community services. Secondly, I think we have to talk about the things that exist already in home and community-based services, things like electronic verification, recertification of providers, the fact that services have to be cost neutral that are already guardrails. And then finally, I'll just say, if there is seriousness about going after fraud in these programs, then you have to use a fine-tooth comb to go after fraudsters. The freezing of fundings that impact the very people that you say you are trying to protect does not achieve that goal. And we can send people even more articles, but I think and show up. Energy and Commerce is holding a hearing tomorrow. There's been a series of hearings. I think people need to see the faces of who we are talking about when there's this narrative of, oh, we're paying families to do something that we're paying for things families should do. Really, we're talking about children with G-tubes and trachs. We're talking about parents with dementia. This is not, we're paying people to sit around and watch TV, and that is just not the reality of who we're talking about.
There's really two separate questions here. One of them is, are we providing benefits to people who should be receiving those benefits? And the second question is, are there people who are ripping off the system? And I think it's important that we separate those two questions. And as Mark and Alison say, clearly there's fraud. I mean, any big federal program is going to have some fraud, and the job of the federal government and states is to go after the people and stop it. But you don't penalize all those other people who are not committing fraud by making blanket cuts in these programs and making victims out of people who are just kind of casualties of kind of frankly what's an ideological attack.
Right. Thank you all for that. And just for a couple questions in the chat, yes, this is being recorded and we will be sharing the recording and the slides afterwards. There's one question for you specifically, Alison, and then would love to just do a quick round with all of you before we close out. So Alison, can you share the implications of the administration's recent opinion undermining Olmstead and how that intersects with this conversation we're having today?
Yes, and if someone could maybe like pull that NPR article, I think that was a really good one if you just type my name in NPR. Since we only have 30 seconds, I will say, as my teenagers say, the TLDR. For 50 years, the position of the United States since the passage of disability rights laws have been that states have an obligation to provide community-based services and cannot unjustifiably institutionalize people. The Supreme Court said that in the 1999 decision, and it is profound, and I don't want to understate that the Department of Justice has put out a guidance saying we don't believe that position was ever correct. We shouldn't have put out these integration mandates, and we read the Supreme Court's decision narrowly. They cannot change the law, only courts and Congress can. And one of the major enforcers of Olmstead and the integration mandate has been the Department of Justice and HHS Office for Civil Rights. They will no longer be doing that. They may very well try to change the underlying regulations, and they may try to get courts to adopt this position, which is why I think the disability community and a number of aging organizations that have used Olmstead as a tool have really pushed back hard against this. And I think it is a really important organizing tool as we are honestly dealing with not having federal guardrails, civil rights guardrails, as we have states dealing with $1 trillion in cuts to Medicaid that may very well land disproportionately on home and community-based services. I'm happy for anyone to follow up directly with me, and I can ask NACI in follow-up to this to share the many articles that have been about this and statements from organizations.
Great. We're happy to do that. And in our last minute, would love to just do a quick round from each of you all. What do you recommend people do to plan for themselves or their families as they age, given, the current challenges we're facing in our system? I pass it off to whoever would like to start.
So I'll jump in. So my view about this is, government supports are shrinking in the current environment. So people are going to have to take the responsibility to do this themselves. That means saving at a younger age. It means thinking about insurance. It means talking to your family about your needs and desires in old age, confronting these issues. Right now, don't count on government support. Not going to be there.
So I'll take a somewhat contrary view to keep this a little spicy. I think that policy never happens unless there's demand for it. And usually it only happens or it starts from the ground up. And so I think as more people get educated about this, they need to get involved. They need to get in touch with their legislators and congresspeople and say, hey, there's this problem out there. We need a solution. We're starting to see that around states. And We have to keep doing that. That is not to negate a single word of what Howard said. You have to do that. Hope is not a strategy, but you have to continue to advocate for change.
Yeah, and I will land on ending with a both and. We are in a very consequential moment where I think we have got to be on the defense. We are trying to protect the little bits that we have of a system, and I think engaging around that is incredibly important. And a national fight to save Medicaid has now moved to a 50-state fight to preserve home and community-based services. And I'm going to end with a favorite quote from my friend Marc, who shared it with me. I think the momentum is there. I think the visibility is there. I think the demographics is there. And the decimation has some ways created this momentum where I honestly think that the politically impossible is becoming the politically inevitable. And we will, at some point, I don't know if it's 3 years from now or 5 years from now or 15 years from now, but we have undeniable momentum that we will someday actually have a long-term services and support system. And we want to leave people with hope, engage. This is so important. And for all of you on here, whether this is your bread and butter daily or you're dabbling in this, we have a space for you, as does NACI, in this really, really important work. So I really want to thank everyone for attending. Marc, Howard, and I lead some kind of affinity group for NACI around long-term services and supports, and we hope all of you will help be part of that because we need to work together to achieve some really big things here.
Well, thank you all so much for your time today. We will share resources with all of you attending afterwards, and it will be available on our website. Appreciate you all for joining us and hope you enjoy the rest of your day. Thank you so much.
Thanks, everybody.
Thank you.